going to present Cardiac Imaging 2020, and of course, it would be a whistle-stop tour, and just want to give you a bit of a flavor of cardiac imaging. As you know, I have a bit of an interest in cardiac imaging, and I spent 2 years in the UK to learn MRI, echo, and CT, and I'm accredited in it. Well, there's a way to think about cardiac imaging. So there's 4 modalities. One using radioactive molecule or agent or tracer, one using an X-ray, one using an ultrasound, and one using a magnet. And this is what I'm talking about: nuclear imaging, CT scan, echocardiogram, and cardiovascular magnetic resonance imaging. Well, nuclear imaging falls under nuclear medicine. These are basically, the sort of really specific indications for nuclear imaging. Like you can use them for sarcoidosis or device infections like pacemakers, prosthetic valve endocarditis, vasculitis, and ischemia testing. Okay, let me get on with it. So let me just. This is the PET scan. It's actually something very American. It's very popular there. I don't think in Sabah we have PET, but we have SPEC. PET CT is useful for vasculitis, as you see. EULAR has recommended this modality for vasculitis. And the American Thoracic Society has also recommended PET CT as one of the modalities to image cardiac sarcoidosis. As you know, it's systemic, and it's very good at picking up disease activity. So if it's in the heart, you pick it up in the heart. But of course, in the end, it's always useful to have tissue biopsy. Okay, this is just a picture of an MRI and PET scan side by side, just complementing each other. So you could see with my arrow here, all these deposits in the mid wall, subepicardial, subendocardial, and you see the corresponding images of the PET CT here. All this disease activity here, and you see after 5 months of immunosuppression, you can see the late gadolinium enhancement also reducing, and also you can see that the disease activity is reduced. Okay, so the other indication for PET CT is prosthetic valve endocarditis. So you could see that in the ESC guidelines, they have actually put in the sort of one of the recommendations here. If you are sort of stuck and you're not too sure, nuclear imaging is one of the methods to pick up inflammation in the prosthetic valve. Okay. And likewise, if you have a pacemaker or any device for that matter that's sort of in your body, nuclear medicine is good in picking up disease activities. You see the sensitivity is 87%, the specificity is 100%, and this is unique for nuclear medicine. Okay. Okay, just for nuclear medicine, how do they do ischemic testing? This is the normal one. So you see, this is a normal donut, and it's sort of there's no filling defect. This is the short axis view, and this is the 4-chamber view, and this is a 2-chamber view. So these are all the normals. Okay. Okay, so this is with right coronary artery ischemia. So you just can see all the inferior wall has no uptake. So that means the right coronary artery has a stenosis. Likewise, in the infraseptal wall and in the inferior wall, there is reduced uptake of the FDG. And for the LAD, the anteroseptal wall, the sort of the apical walls, apical and apical part of the myocardium is not picking up. Okay, so that's my sort of fast run through of the nuclear medicine. part of cardiac imaging. So I go to CT scan. So the big thing about CT scan is they are very good at coronary artery disease and ischemia testing. So just a brief reminder, the atherosclerotic disease pathway, fatty streaks first, then it becomes more calcified, becomes vulnerable, it ruptures, and that's how you sort of get your heart attack, myocardial infarction. Okay, just coronary artery calcium scoring is something that's done in CT scan, and it's a very good marker risk factor for myocardial infarction. So much so that if your calcium score is 0 and your atherosclerotic cardiovascular disease risk score is more than 7.5%, like say you're between 15 and 19%, if your calcium score is 0, you may not benefit from statin. Okay, and when do you do the calcium score in CT scan? This is the ESC guideline where you may do in individuals where there's low or moderate risk based on your sort of score, severe risk, and the LDL goal is not achieved with lifestyle. Okay. Okay, so this is the sort of the CT scan. When do you do it? Of course, you can do it when patients are symptomatic, like atypical, low to medium risk, to look out for obstructive coronary artery disease. And this usually means more than 50% stenosis. Or you could sort of try to risk stratify some individuals who have a lot of risk factors. Okay. So this is the ESC guideline, and if you think he has low to a medium likelihood of obstructive coronary artery disease, you think you suspect coronary artery disease, and you do a CT scan. This is one example of obstructive coronary artery disease. This is like a soft plaque right here that's sort of causing stenosis in the proximal vessel. Okay, so in terms of LDL goal, is kind of useful to know that if you come across like a CT scan that says there's multivessel disease and there's more than 50% stenosis in 2 vessels, then your target for LDL would be 1.4 millimoles or below. Okay, or with any one of these, or with any one of these risk factors. All right. Okay, so for ischemia testing, there is this sort of sequence that you can buy. You have to buy this proprietary sort of software that can calculate the sort of FFR, and this is sort of like calculating how good the flow is in the distal artery compared to the proximal artery. And if the ratio is 0.8 and below, the red part of the artery is considered ischemic and would need some revascularization. Okay, so this is one of the newer things that's happening. But some say, why don't you just do everyone FFR CT? But there's just a recent sort of study that came out, forecast, that did not see any cost saving, but it did reduce the use of invasive angiography. Okay, so SCOT heart trial is on everyone's mind, and we know that 50% of MI happens in people who have not had any obstructive coronary artery disease. Okay, and these are people who you suspect coronary artery disease, and then you randomize them to a CT first, and then assess, or you just go by standard sort of care. And this SCOT heart trial demonstrated that after 5 years, doing a CT actually caused people to be more compliant to therapy, and there's a trend to more initiation of statin after CT coronary angiogram because of the plaque that was seen. Okay, so to talk about plaques, only a small portion of ruptured plaques causes clinical events. Not all of them cause an MI. 40% of them become, this is the thin cap fibroateroma, and some of them don't get plaque rupture, they become a thick cap fibroateroma, and some become fibrotic, whereas some of them goes into plaque rupture, and most of them heal. Those that don't heal becomes a myocardial infarction. So this is something very topical. They talk about scanning the vulnerable plaque. Okay, so so you can scan for this using OCT, this optical coherence tomography. This is something that's you can do in your invasive lab. IVUS is the intravascular ultrasound that you could do in your lab. And there are some nuclear medicine techniques where you can demonstrate disease activity in the coronary arteries. That's something that's done also. So this is what I mean by plaques that are vulnerable, that are prone to give you an MI. So you do see this in your CT coronary angiogram. That means you have a vulnerable plaque. This is a napkin ring sign. Basically means there's calcium more than 180 degrees. There's low CT attenuation, meaning there's soft plaques here that could be bound to rupture. These are spotty calcium, and this is just a positive remodeling. The vessel gets bigger, and the sort of plaque is sort of extra vessel, extramural. Okay. So what's the point of sort of demonstrating this vulnerable plaques? If you see them, then you may be prone to start statins, basically, or any of those PCSK9 inhibitors, or your usual statins. Okay, so now I go to my next modality, ultrasound, echocardiogram. Of course, it's still the king in the assessing valvular heart disease because of its spatial resolution, and also is used in ischemic testing. Okay, I'll just give you a second to digest this. Okay, what you see is there is calcified, sort of very restrictive aortic valve. There is left ventricular hypertrophy that's concentric, and what else? The left ventricular ejection fraction is reduced. Okay, so this is what you can see in low flow, low gradient aortic stenosis. So just to give you, just an idea, the flavor of how we sort of decide when to intervene. Okay, so you can basically divide them into asymptomatic. All right, then you just measure the flow through the aortic valve. So the sort of more calcified they are, the faster the flow that goes through them. So once the mean gradient is above 40, that's already severe range. High gradient. Okay, and when you are symptomatic, we look at your mean gradient, we look at your aortic valve area, we look at your left ventricular ejection fraction, less than 50%. Then the stroke volume. Okay, I'm not gonna go into detail, but just giving you a flavor of how we think through things. So, like the cine that I showed you just now, that patient it falls into the low flow, low gradient aortic stenosis. So you just assess the valve, and the valve is small. You look for errors in measurement. You measure flow. You measure the LV ejection fraction. If it's still low, you sometimes give some dobutamine to boost the flow, just to demonstrate whether the patient has pseudo severe aortic stenosis or not. Okay, and this just more the same. Okay, so back to this. This is something topical. So why you come across a patient that is asymptomatic, and the patient has severe aortic stenosis by Doppler. okay? And he remains asymptomatic despite doing your exercise tolerance tests. With their BNP, that's up to 2 folds, but not up to 3 folds. The EF is normal, and the peak jet velocity is 5.1 meter per second. Above 4 meter per second is severe. But the aortic valve area is severe, definitely. So what will you do? In this asymptomatic severe aortic stenosis patient with preserved EF, do you just watch and wait, or do you do early prophylactic aortic valve replacement? And this is something very topical. So other things we look for is whether they have fast progression of the flow through the aortic valve. We do measure. You can measure the BNP. You can do a valve stress test doing an exercise with the blood pressure drops. You can check estimate their systolic pulmonary artery pressure. Okay. So this is an article that came out from the Koreans. So they basically did the early surgery versus watchful waiting in patients who have aortic valve of less than 0.75 centimeters square and an aortic valve velocity of more than 4.5 meters per second and a mean gradient of above 50. So some of these patients, we do watchful waiting, but the Koreans found that after 5-6 years, early surgery seems to be, reducing mortality. So this may play into the recommendations later. And the other thing that's sort of topical about aortic stenosis is TAVR, which is transaortic valve replacement, which is a device that you put into the aortic valve to act as a valve. And this is a study that's ongoing. And I think it may inform our decision soon. Okay, so just to give you an idea of what a TAVI or TAVR is, this is your transaortic valve replacement. It can be a balloon expandable type or self-expanding type, and this is how you look at in echo. Okay. Okay, so in any valve disease, it's good to sort of look at them through the damage it causes on the heart. First, it causes left ventricular damage. Then move on to left atrial other valve damage. Then they start to affect the right heart system, the pulmonary artery, the tricuspid valve. Then it start to cause subclinical heart failure. So these are all the question marks that may be answered by sort of ongoing trials. Okay. So just to let you see what aortic regurgitation looks like in the 5-chamber view. This is aortic regurgitation, and we do our measurements here. We do our Dopplers here. Okay. And this is the pathway that we use. We look at the LV dilation. We look at symptoms. We look at the aorta and determine whether they need surgery. Okay, so the take-home message is, determine who is at risk for surgery, for disease. We follow them up. If they're asymptomatic, we see if they have any severe disease. And based on the parameters I've told you, some may benefit from early aortic valve replacement. Okay. I'll let you look at this for a while. Okay, you will have noticed that the posterior mitral valve leaflet is prolapse and causing an eccentric anteriorly directed jet going up here and looks severe. Okay, so in terms of timing for intervention in mitral regurgitation, the longer you wait, the more symptomatic they are. At the time of repair, their mortality rises through the years. Okay. Same also, if the ejection fraction, the more longer you wait, the lower the ejection fraction, there's an effect on survival. Also, if there's atrial fibrillation and pulmonary hypertension, it also affects survival. Left atrial size also has an effect on survival. Also, BNP, the brain natriuretic peptide, the higher the BNP, your survival starts to drop. Okay, these are the benefits of early intervention, and a 15-year outcome of when you intervene when patients are asymptomatic with LV dysfunction and when patient has symptoms, does affect outcome. And the other factor is hospital and surgeon volume. When you see that they do about 200 cases per year, you see that the mortality drops, and the mitral valve repair success rate increases when you hit 200. Okay, so that's why all these parameters play into trying to get the patient to surgery soon. As soon as the LV dimensions reaches a certain dimension, when the LV ejection fraction reaches a certain dimension, then we need to look at also whether the surgeon has done a lot of mitral valve repair. And I think our center does do a lot. Yeah. Okay. So the other thing that affects prognosis is whether they have whether they have fibrosis. Okay. And the more severe the MR at the time of diagnosis, the mortality increases. Okay. Okay. This is just just how to look at mitral regurgitation. So if there's primary mitral regurgitation, it will have an effect on the left atrium. It will dilate, and they'll be more prone to atrial fibrillation, which in turn increases left atrial pressure. And this will all play into dilating your left ventricle, which will dilate your mitral annulus, which will actually also affect your mitral regurgitation. Okay. All in all, with valve disease, it's quite important to have a heart team, be friends with your surgeon, and time your procedure. So communication is key, and collaboration. Okay, not to forget, this disease is still very prevalent. It's been described in 1900s in the Lancet, and it's still with us today. Let you look at it for a minute. So this is mitral stenosis. So you could see this sort of reverse hockey-stick appearance, this restriction in diastole and systole, and you can see the sort of the turbulence of mitral stenosis here. Okay, and severe mitral stenosis, we still take it at less than 1 centimeter square. And if they are symptomatic with a favorable valve morphology, that means Wilson score of 8 and below, then we still do percutaneous transmitral commissurotomy at our center. If they are not suitable, we'll refer them for mitral valve replacement. Okay, this is just a sort of the ischemia testing part of the echocardiogram. Basically, you see the wall of your left ventricle. Sorry, I don't have the CNE for it. Basically, if it's not moving, and once you sort of give a stressor, and the myocardium starts to move again, it is ischemic. But if you give a stress like you exercise or pharmacological, If the sort of muscle doesn't move with low stress or high stress, that means the muscle is not viable. Okay, there's sometimes the heart doesn't move. You give them a low stress, it will move a bit. Then you give a high stress, it hibernates. This is a biphasic response, and this is still viable. Okay. All right, I go to my last modality, which is cardiovascular magnetic resonance imaging. I like this slide because you know, MRI is good at looking at the structure and function of the heart, and you know, as cardiologists, you know, when there's cardiac arrest, sometimes you just want to know what caused it, and you know, if there's any unexpected masses in the heart, is good. Rare diseases, when other modalities, you know, before this they can't get a diagnosis, MRI is a good one to look at. Okay. Okay, just want to let you see how cardiovascular magnetic resonance imaging looks like. This is just sort of your short axis slices. And this is basically, this is a normal sort of contraction of the heart, okay, from the base to the apical heart. So the one moving here on the left side is the two chamber, and there's a thinning of the wall here, and it is akinesia here. That's because this patient had inferior MI. This is the same patient, three chamber. All the walls are thickening quite all right. For this patient, the infroseptal wall is a bit hypokinetic here. The RV is contracting quite all right. Okay, this is the right heart. This is your pulmonary artery. So the right ventricle is a bit reduced in contractility. And this is your tricuspid valve. This is your RV apex, and this is your infundibulum going into the pulmonary valve. Okay. So MRI is a very good technique to look at the structure and function of the heart, and it's actually gold standard in assessing LV ejection fraction. And the other thing that sort of differentiate a cardiac MRI from the other modalities is tissue characterization. Okay, I've shown you how it looks like in cardiac MRI. We can do sequences to see what are the tissues like. So this is like the T2 stir sort of imaging, edema imaging. So basically you see a lot of white sort of shadowing or opacification. There's edema there, and that may be your inflammation going on there. And this is late gadolinium enhancement. The gadolinium goes into the extracellular space where there's tissue injury, and will delineate where the myocardial injury is, and depending on the pattern, we can know whether it's ischemic or non-ischemic. But there are some limitations for conventional MRI. Those look for focal fibrosis. Sometimes you can have a heart that is sort of beating poorly like this, and the T2 stir edema imaging looks like that, and the late gadolinium enhancements look like that. And so we go to a sequence that looks at diffuse fibrosis. So this is T1 mapping, basically looking at the entire heart and looking at sort of edema. And there are values that are considered normal. This is extracellular volume, and if there's amyloidosis, these values will go very high. And it gives us a way to differentiate diffuse fibrosis. So this is what you see on stress perfusion MRI, as you know from the ischemic cascade. Here, the perfusion defect is over here. If you compare to your anterior wall, there's a perfusion defect in your inferior and infroseptal wall. So this patient has a right coronary artery stenosis. Okay, All right. So some people say that cardiac MRI is almost like a virtual biopsy. So over here, this is what you see in a patient who has anterior MI. So this is the pathology. You can see this is all dead tissue, dead myocardium tissue, and it shows up. The late gadolinium shows a transmural all scar tissue, and this is T1 mapping, showing that there's just no disease activity there. All right. So the unique capability of an MRI is tissue differentiation. Again, you can do it with or without contrast media. Okay, you can demonstrate focal fibrosis that I mentioned, like in infarction. You see this edema. You can see this on T2 stir, and this is usually something you can see in myocarditis. And this sort of thickened myocardium you can see here. It's usually something that happens in hypertrophic cardiomyopathy, but in this sequences, if you do a leg gadolinium enhancement, you probably could see a patchy enhancement in the mid wall. Yeah, these are your T2 mapping sequences. Okay, so what I just want to say is in the ESC guideline 2016, if you have heart failure, MRI should be one of the modalities to think about to differentiate the myocardial tissues into these differentials, whether it's myocarditis, amyloidosis, sarcoidosis, fabris, hemochromatosis, SLE. This is just a picture on some of rheumatoid arthritis having inflammation. They're seen over here, focal fibrosis here, and also seen in the T1. Okay. And this is just the patterns that you can see in cardiac sarcoidosis. So your late gadolinium enhancement gives you a lot of patterns, and in sarcoidosis they say it's usually patchy and all over. You can see all this sort of enhancement, and it will show up in the MRI as such. Okay, this pattern seems to be specific for cardiac sarcoidosis, but still tissue biopsy would be useful. Okay, so the ESC has published a lot of 2020 guidelines, and this is in the NSTEMI 2020 guidelines. Oftentimes someone comes with chest pain and the troponin is raised, and not much ECG changes, and you do your coronary angiogram, and your coronary angiogram is normal. So one of the things to do is to think about is cardiac MRI imaging. All right, whether it's a true MRI that will give you a subendocardial pattern, or Takotsubo. It could be myocarditis. It could be MINOCA, myocardial infarction with non-obstructive coronary artery. Okay. All right. This is the sort of the updated Lake-Lewis criteria. I think in 2018 they incorporated cardiac MRI in the main criteria. So you could demonstrate T2 weighted imaging. This basically showing edema. So this is all your edema in your myocardium, and T2 mapping is showing the activity of that. I mean, similar sort of tissue characterization. Okay, and all the sort of the late gadolinium enhancement that you can see in myocarditis, that will sort of point you towards the diagnosis of myocarditis. Okay, so I hope my whistle stop tour of the cardiac imaging modalities is enough to give you some flavor of how cardiac imaging is, and I hope you are more aware of how we image the heart. Thank you.